Doctors, how is everyone doing today? I just want to know how you are doing. It's exciting to see you. So please, I really want to enjoy the day with you. And today we are starting early. I want to know from the comments, first and foremost, is the microphone working well today? I really want to know whether you can hear me clearly because I've done my best to make sure I set it up. So before the class even starts, please let me know whether the microphone is clear. Do you hear me clearly? Do you hear me clearly? Please, I want to make sure. Okay, so Dr. Joanna says it's clear. Dr. Musima says it's clear. Everyone says it's clear. Clear, clear. Good, good, good. So it looks like things are working. Okay, so now let's jump into the class and start it right away. Let's jump into the class. Beautiful. So today we're going to deal with um, DVT, which is a very, very important subject, but we may have to do it over 2 classes, okay? Because I want us to solve a lot of questions. And someone also told me that they really like the equation part of things. So we'll also be doing an equation part of the class as we get to the end. And then we will also do active recall. So please, if you have any friends who are yet to join us, tell them to join us right away. I'll be monitoring the comments in the comment section. Please kindly click on the like and the subscribe button. We are 2,800 subscribers. I want us by the end of this class to have hit 3,000 subscribers. The reason is because it helps other people all over the world to see that, look, this is content people are interested in. And I promise you, I'm really committed to making sure that we meet every Sunday to study. So whether you're a medical student, you are preparing for your PLAB, your USMLE, and especially your MCQ1, this class is for you. And today we are going to deal with DVT. We're going to deal with DVT. Okay, we're going to deal with DVT. So let's get the ball rolling. And I'll be monitoring the comments. So if you have anything, let me know, and we will get it going for you right away. I think what we also need to do is to make sure that those who are joining us on Facebook also get this. So I'm going there, sharing the link with them because people on Facebook are waiting to hear something, right? Just hold on. Just waiting to make sure they get it. Okay, so I'm just sharing the link. So if you are joining us on Facebook as well, you're going to get a YouTube link there, and that will help you to join the class right away. I'm very glad that you are joining us. Please, if you have anything, while I share this on Facebook, kindly share it with your friends, at home in the various WhatsApp groups and the rest, so that they can all join and we'll get things going. So those on Facebook, I've shared it there, and those on my personal page on Facebook as well, I'm sharing it there as well. You can also watch the live class on Facebook. You can watch it on Facebook. So let's go. Let's get the ball rolling right away. Let's get the ball rolling. And I'm sharing it publicly so anyone can see it. Okay? Good. Yeah, doctors. So now the game can begin. So again, you can hear me clearly. We can start the class. Okay. So today we are dealing with different thrombosis, and we're going to start with some questions as usual. We're going to start with some questions as usual. Okay. So let's start. A 58-year-old man presents to the emergency department with a 2-day history of left calf swelling and discomfort. He recently underwent hip replacement surgery and has been mostly bedbound. Vital signs are stable. Examination reveals left calf tenderness with mild erythema and pitting edema. You suspect deep vein thrombosis. Which of the following is the most serious potential complication if this condition is left untreated? A. Post thrombotic syndrome. B. Pulmonary embolism. C. Cellulitis. D. Superficial thrombophlebitis. And E. Chronic venous insufficiency. Please answer the question. Let's go. I'm just waiting for your answers. So I see a lot of people going for B, which is pulmonary embolism, and that is the truth. So B is the correct answer. The serious and potentially fatal complication of patients who have untreated DVT is pulmonary embolism. Okay, and pulmonary embolism occurs when the clot in the leg travels to the lung. And I'll take my time when we go to the deep dive to talk about what DVT is and all the nuances of it. Um, so why is A wrong? A is post-thrombotic syndrome. A is wrong because A is a long-term complication, okay? And it's not necessarily life-threatening. And then C, which is the lightest, is a soft tissue infection and it's not a complication of DVT. So B is the correct answer, and that is why we went for that. Okay, good. Let's go for the next question. You have a 45-year-old woman on oral contraceptive pills presents to a primary care clinic for a routine visit. She has no symptoms, and you are reviewing her risk factors for venous thromboembolism, which are the following statements about venous thromboembolism is most accurate. Is most accurate. Is most accurate. A. Pulmonary embolism is more common than DVT in venous thromboembolic cases. B. Venous thromboembolic embolism is rare, affecting less than 1 in 10,000 adults annually. C. DVT represents the majority of clinical venous thromboembolism presentations. D. Venous thromboembolism occurs more frequently in women than in men. And E. Hormonal contraception is not considered a significant risk factor. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? Talk to me. Type in your answers. Let's go. Type in your answer. So I can see that there's a battle between B, D, and C. So B says venous thromboembolism is rare, affecting fewer than 1 in 10,000 adults annually. And why are people also going for C? They are saying DVT represents the majority of clinical venous thromboembolism presentations. And some are also going for D. They are saying VT occurs more frequently in women. But it looks like as the questions are being answered, I see more people are going for C. Dr. Pimbola, Dr. Raphael Boke, Dr. Nifemi, Dr. Mengolo Suzanne are all going for C. The correct answer is C. Please note this. Please write it down in your book. Write it down in your book. Okay? Write it down. DVT represents the majority of clinical venous thromboembolism presentations. So even though pulmonary embolism can occur and DVT can be complicated by pulmonary embolism, DVT is more common than pulmonary embolism. Now, what about the issue between males and females? Because don't forget that if you are going into an exam which is focusing on MCQ, all right? If you're going into an exam which focuses on MCQs, you want to make sure that you are sharp with a lot of things. And some of the things you want to make sure you are sharp on are even numbers. Okay. So, number one, the first thing you have to understand is that DVT is more common than pulmonary embolism. Number two, the incidence of DVT, and I'm going to share my slides again. The incidence of DVT, okay, the incidence of DVT is about 1 in 1,000 adults. Please write that down because that's very important. It's about 1 in 1,000 adults. Write that down. 1 in 1,000 adults, not less than 1 in 10,000. The incidence of DVT is about 1 in 1,000. So if you pick every 1,000 adults, one of them will develop DVT. Now, the issue, male and female, who is more affected as far as DVT is concerned? What you will learn is that it is more common in males, slightly. In fact, the literature uses the word slightly more common in males as compared to females. And everybody knows that hormonal contraception is a known venous thromboembolism risk factor. Okay, everybody knows that. Even the child who is just born now knows that. Okay, let's go to the next question. Let's go to the next question. We have a 68-year-old hospitalized man develops unilateral leg swelling on day 5 post abdominal surgery. You suspect a deep vein thrombosis, which of the following populations is at highest risk for developing DVT. So the following populations is at highest risk for developing DVT. A. Healthy ambulatory young adults. B. Patients undergoing minor outpatient procedures. C. Postmenopausal women on no medications. D. Hospitalized patients, especially post surgical or with cancer. E. Patients with isolated superficial varicose veins. Which of the following populations is at highest risk for developing DVT? So the following populations is at highest risk. Is it A? Is it B? Is it C? Is it D? Or is it E? And I see a lot of us are going for D. D. This is very obvious. D. So hospitalized patients, especially post-surgical patients with cancer, are at highest risk. Right? So in a patient who is active, a young man who is active, the risk of DVT is very low. Okay, and minor procedures do not significantly raise DVT risk factors or the risk of DVT. And many many have a baseline risk factor, but not as high as D, which is hospitalized patients, especially post-surgical with cancer. So that is why we decided to go with D. So, doctors, I'm hoping this first part has really opened up. Remember, we've not even started teaching yet. This is just something to get us into the game, right? This is just questions to get us going. So it's now that we're going to do a deep dive into DVT itself, the introduction, and then we'll go to another set of questions and we'll do another deep dive. So when we are teaching in MedCognito, that's how we start questions just to test your knowledge before we go into the concept, and then we test questions again, and then we go into deep knowledge, and then we test. That's how we do it, okay? So that it can reinforce. Then when we are done with the class, then do active recall. Active recall means now I'm not giving you options to choose from. I'm rather asking you the questions, and you are supposed to provide me the answers. So let's get going. Let's do a deep dive. So what is DVT? What is DVT? Basically, DVT means you have a clot in the deep veins of the leg. Most often, that clot is either in the thigh or in the calf. Okay, so you have a clot, and that clot is in the deep veins of the leg, and that clot is often in the thigh or in the calf. Now, why do we care about DVT? And remember, all the objectives of the exam, if you remember, they are always focusing on life-threatening things, limb-threatening things, emergencies you must know. So why do we care about DVT? We care about DVT because when that clot forms in the calf or in the thigh, it can travel to the lung and lead to pulmonary embolism. When that clot is formed, it can travel from the leg all the way to the lung and can lead to pulmonary embolism. At the same time, there's also a case we call paradoxical embolism. Why do we care about DVT? Because there can also be what we call the paradoxical embolism. And a paradoxical embolism basically means that that clot can travel and go to the brain, and that can lead to a stroke. Okay, that can lead to a stroke. That can lead to a stroke. Yeah, Dr. Joanna De Cruz. Yeah, this is just warm up. We've not even started the class yet. This is just warm up. All right. Good. Who does he apply on it? It's about one in every thousand adults. One in every thousand adults. So you pick 1, 2, 3, 4, 5, 6, 7, 8, 9, 10,000. One in every 10,000. One in every thousand adults will develop. Now, who is it more common in males or females? It is more common in males. So please make sure you write this in your book, your notebook, so that you can always remember. Okay, it's more common in males. Now, we're going to look at DVT clinical presentation and history. We're going to look at DVT clinical presentation and history. And so we're going to start with questions again. First question is that you have a 62-year-old woman who presents with a 3-day aggressive left calf pain and swelling. She reports no recent trauma. She's otherwise healthy, takes no medications, and denies chest pain or dyspnea. On examination, the left leg is warm, erythematous, and swollen. Calf circumference is 4 centimeters larger on the left compared to the right. There is tenderness along the posterior calf. Which of the following findings is most useful in supporting a clinical diagnosis of lower extremity DVT? Again, I can take the question again. Which of the following findings is most useful? That's the caveat. Is most useful. Which of the following findings is most useful? Is most useful. Okay? Is most useful in the clinical diagnosis of lower extremity DVT. A. Pain on passive dorsiflexion of the foot. B. Subjective complaint of leg pain. C. Erythema and warmth. D. Calf circumference difference. And E. Tenderness along the superficial veins. Is it A, B, is it C, is it D, or is it E? Doctors, help me. I see a lot of doctors are going for A, A, A. Which of the following findings is most useful in supporting a clinical diagnosis of low extremity DVT? And I'm very happy about seeing. Ooh, it looks like so far only Dr. Sabine got it right. Dr. Sabine is the only one who got it right. Dr. Sabine chose D. Everyone is going for A. But Dr. Sabine decided to go for D. And why am I saying that? Calf circumference difference is the most useful physical finding. Doctors, please, if you have a patient, calf circumference difference is the most useful physical finding in DVT evaluation. Let me say it again. Calf circumference difference is the most useful physical finding in DVT because it suggests unilateral swelling and localized clot bed. Okay. Now, many of you went for A because A is describing what we call Holman's sign, pain passive flexion of the foot. And I know back in medical school, some people used to talk about it, but the literature tells us that human sign is unreliable, and I'll be making a strong case about that. And it's not recommended as a diagnostic maneuver. Why? Because if actually there's a blood clot there, it can cause a dislodgement of the clot into the lung for the patient to develop pulmonary embolism. Ah, so doctors, please. I'm very happy that this thing came up. When I was setting this question, I was like, should I really do this question or not? But I was really surprised that the majority of people got it wrong. But it's also because of, you know, the fact that the literature is changing. And even though Homan sign was previously taught and people used to fall for that a lot, it is no longer reliable. It is no longer reliable. Okay, it is no longer reliable. And I'll be doing a deep dive into all these things. I'll be doing a deep dive into all these things for you to appreciate it better. I'll be doing a deep dive. So let's go to the next question. Let's go to the next question. Because again, I want to ask, is my voice clear? Can you hear me well? Can you hear me well before I move on? Is the voice clear? Can you hear me well? If you can't hear me well, let me know. Because we've taken time to really work on the microphone to make sure that you can clearly hear. But someone just said, someone just said they cannot hear me well. I want to know, Dr. Sabine, can you hear me well or no? Okay, people are saying it's clear. So I don't know. Um, I'll take a pause here. Let me pause here. Please let me know. Is it clear or not? Is it clear? Is it clear or not? Everyone says it's clear, so I don't know. Yeah. Is it clear? Only one person is saying it is not clear. Oh, okay. Wow, I thought today everything was going well. Okay, some people say it vibrates. Okay, so I'm just trying to speak. Can you hear me well? I just want to know. Let's clear that before. Okay, so let's continue. Someone says let's continue. Now, okay. Awesome. Okay. Thank you, doctor, for the feedback. We are doing this for you. Okay, good. So let's take this question. It says a 58-year-old man presents with right leg swelling and dull aching pain for 2 days. He was recently diagnosed with pancreatic cancer. He was recently diagnosed with pancreatic cancer. On examination, there is unilateral pitting edema, mild erythema, and tenderness along the femoral vein. We suspect a proximal deep vein thrombosis, which are the following additional findings would most strongly suggest a massive proximal or iliac vein thrombosis, which are the following additional findings would most strongly suggest a massive proximal or iliac vein thrombosis. A. Bilateral leg swelling. B. Mild tenderness isolated to the posterior calf. C. Palpable superficial varicose vein. D. Buttocks pain and massive thigh swelling. And E. Pain with foot dorsiflexion. Which of the following additional findings would most likely suggest a massive proximal or iliac vein thrombosis? And I see a lot of us are going for D. That is buttocks pain and massive thigh swelling. So D is the correct answer. If there's iliac vein thrombosis, it may present with massive proximal swelling and buttocks pain. Okay, so if you have a patient with iliac vessel, iliac vein thrombosis, there may be massive proximal swelling and buttocks pain due to the thrombus burden being very, very high. Okay, now let's go to another question. You have a 67-year-old man or woman, sorry, who presents with sudden onset pain and swelling in the left, in her right leg. She was discharged from hospital 5 days ago after a total hip replacement. Now, on examination, her right leg is visibly swollen, tender along the femoral vein, and the skin is warm and erythematous. No dilated superficial veins. You suspect a deep vein thrombosis, which of the following statements is most accurate regarding the clinical presentation of DVT? Which of the following statements is most accurate regarding the clinical presentation of DVT? A. Pain and warmth are highly specific findings for DVT. B. DVT usually presents bilaterally in post-operative patients. C. Physical exam is often unremarkable in DVT. D. Holman's sign is a reliable indicator for diagnosing DVT. And E. Asymptomatic DVT is uncommon and can usually be ruled out by normal examination. Haha. This question has so many nuances, but I really want us to take our time and appreciate it very well. Okay, take your time and appreciate it very well. Hmm. Take your time and appreciate it very well. And type in your answers. Okay, so the correct answer is C. C, 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 C. Physical exam is often unremarkable in DVT. Why is C correct? Because we went, A said that pain and warmth are highly specific findings for DVT. We learned that the most specific finding for DVT is change in the size of the calf. He also said DVT usually presents bilateral in postoperative patients. That's wrong, right? He says physical exam is often unremarkable and he says Homan sign is reliable, but we learned that that's also wrong. And he says asymptomatic DVT is uncommon and can be ruled out by normal. Okay, so C is the correct answer. Many patients with DVT may have non-specific or absent signs. An exam can be unremarkable despite the patient having a blood clot. That is why C is the correct answer. So now let's do a deep dive because I know some people were concerned about that. Let's do a deep dive. Now, the clinical presentation of deep vein thrombosis, the typical symptoms are unilateral leg swelling, not bilateral. Unilateral leg swelling. Okay. The other thing is there can be calf or thigh pain. Calf or thigh pain can also happen, and the kind of pain the patient will present with will be dull and aching. So there'll be calf and thigh pain. But in your board exam, look for that patient with dull, aching thigh or calf. And then when it comes to warmth, there can be erythema and there can also be warmth as well. Okay? Erythema and warmth. And then there can be tenderness along the deep vein, usually the posterior calf or the femoral vein. So tenderness. So please look at this very well. Unilateral leg swelling, calf or thigh pain, warmth and erythema, tenderness along the deep veins, and then visible swelling or tightness of the skin around where the deep vein thrombosis is occurring. So I'm sure many of us, like, when we're coming into this class, we go, oh yeah, it's just DVT, we're going to talk about D-dimer. But before you even get to the issue of D-dimer, Doppler ultrasound, and all those things, these are tricks that you need to really know so that you can be able to ace your exam. All right. That is why I'm really taking my time to go through these things with you. Now, the next thing, what are the classic exam findings of DVT? Classic exam findings of DVT. Number one, you want to see a patient and you realize that there's more than 3 centimeter difference in calf circumference. And that is the most reliable sign. Please, you need to write this in your textbooks or in your notebooks. The most reliable sign physical exam finding of DVT is that there is more than 3 centimeter difference in the calf circumference. There's more than 3 centimeter difference in the calf circumference. That's the most reliable physical exam. The patient may also have pitting edema. Usually it is unilateral. There can be tenderness along the deep vein, the popliteal vein, and then the femoral vein. And there can be warmth or dislocation of the or discoloration, sorry, of the skin. And there can be massive thigh swelling and buttocks pain. And when you see a patient who is presenting with symptoms of DVT, but the signs also point to massive thigh swelling and buttocks pain, please, it should point you to could it be that iliac or the femoral veins have been affected? So you see massive thigh swelling, buttocks pain. Think, oh, right, this could be the iliac vein or the femoral vein, which is especially the proximal femoral vein. Okay, especially the proximal femoral vein. Now, we're talking about the Homan sign, and I was saying that I'm going to make a point about it. Homan sign, which is pain on dorsiflexion of the foot. So if I was setting a question, I could just say the patient has pain on dorsiflexion of the foot, and I may not put Homan sign there. Okay, it's outdated and unreliable. Please don't use it in your board exam. Run away from Homan sign. Run away from it. It is outdated. Don't use doctors, please. Don't use it. Say it again. Don't use it. Now, what are the high risk contexts where DVT presents atypically or more severely? High risk where DVT may present atypically or more severely. Number one, if you have a patient who has had recent surgery, especially orthopedic surgery, be it hip replacement, knee replacement, you know. Number two, cancer patients. Why cancer patients? Because cancer puts the patient in a hypercoagulable state. So usually when I give the risk and I give the context around it. So cancer patients. And then if there's prolonged immobility, so the patient has been traveling by air for a long time, and the patient never got up to walk, or the patient never used compression stockings, and as well as patients who have been on hormonal therapy or contraception, and then asymptomatic DVT is common in post-op or oncology patients and may be picked up only through screening or incidental. Yeah. Dr. Nimat also asks, what about pregnancy? Yes, pregnancy is also a hypercoagulable state as well. Okay. But we are looking at the high risk context where DVT presents atypically. We're looking at atypically, right? Again. Now, proximal and iliac DVT red flags. These are the things I want you to look for. Remember, we've already talked about it. If you're looking at proximal femoral vein or iliac vein DVT, what are the things you need to look out for? Look out for that patient with massive thigh swelling. Please write this in your book. Okay, these are very specific stuff, right? And for me, people ask me, oh, the CDM and the MCQ, which is more difficult. I don't know. But the issue with the MCQs, which you're now doing, is that you need to have a lot of depth of knowledge, right? So I'm sure now you are realizing that DVT is not just D dimers and Doppler ultrasound. We've not even touched on that. But look at all the things we are talking about, right? All the things we are talking about. So Dr. Kwame is asking, can they use long flights as a trick? Do we look for more specifics before drawing conclusions? Yes, doc. Especially because now the exam is MCQs only. You want to make sure that you are sharp. You are sharp. That's why I want us to take our time. When we pick a topic, we don't rush through it and we take our time to go through it. And proximal femoral or iliac DVT, it may also show compression symptoms where the patient may have neurologic or venous, symptoms. So that's what you need to know. And they may indicate iliofemoral DVT, which we talked about, which carries higher risk of embolization. So if you're looking at DVTs, the one with a very, very high risk of embolization, that is the blood clots traveling into the lung, is the iliofemoral type. Okay, the iliofemoral. So I got this picture for you. So you have proximal. So when we talk about proximal DVT, we are talking about those happening in the external iliac vein, common femoral vein, and then the femoral vein as well, and then the popliteal vein. So I need you to write these down. Which veins are we referring to when we talk about proximal deep vein thrombosis? We are talking about external iliac vein, common femoral vein itself, and then the popliteal. And then which veins are we talking about when we talk about distal TT? We are talking about anterior tibial veins, peroneal, and then plantar metatarsal veins. This one I need you to really, because you can be quizzed on this easily. You can be quizzed on this. Which veins are we talking about when we talk about the proximal DVT? Which veins are we talking about when we talk about distal DVT? Very, very important. So let's start with some questions about labs and differential diagnosis in suspected DVT. Labs and differential diagnosis. So this is where we may start talking about D-dimer. Okay. So again, DVT is not only about D-dimer. In subsequent classes, because today I want us to take our time and focus on some critical things. In subsequent classes, we're even going to do a deep dive, what we call high probability, low probability. When do you do D-dimer? When do you jump from D-dimer and go to do ultrasound right away? But let's start with some questions. Okay. So you have a 70-year-old man who presents to the ED with right leg swelling and mild pain. He has a history of hypertension and is post-6 from a total knee replacement. On examination, his leg is swollen and erythematous. You suspect deep vein thrombosis. Routine labs, including complete blood count, renal function, liver enzymes, and coagulation studies, are within normal limits. What is the most appropriate interpretation of these normal results? Ha ha ha. What is the most appropriate interpretation of these normal results? A. They exclude DVT in a post-operative patient. B. They confirm that the swelling is due to venous insufficiency. C. They are diagnostically sufficient to confirm DVT. E or D. They help evaluate possible underlying causes or comorbidities. And E. They should be repeated daily to track clot burden. Why do you do these labs in a patient with DVT? Is it to exclude DVT in a postoperative patient? Is it that they confirm that the swelling is due to venous insufficiency, that they are diagnostically sufficient to confirm DVT? They help evaluate possible underlying causes or comorbidities, or they should be repeated daily to track clot burden. What's the correct answer? And I see a lot of doctors who are going for D. A lot of doctors are going for D, and the correct answer is D. Why do you do liver function test, kidney function test, coagulation, and all those things? D is correct because routine labs are not diagnostic of DVT, but they help to assess comorbid conditions. Okay, medication safety. So why are you doing coagulation studies? It depends on anticoagulants and possible causes like liver disease or malignancy. So the reason why you are doing all these labs is so that they can help you to assess comorbid conditions. What you have to understand is that labs do not rule out DVT. Labs cannot confirm venous insufficiency. Labs cannot um confirm DVT. Sorry, so I said labs, the labs I just talked about, they do not rule out DVT, but there's one lab which can help us to rule it out. Okay. And then E, daily repetition is not necessary unless monitoring therapy or I have another question for you. So you have a 56-year-old woman who presents in the clinic with mild left leg discomfort and swelling for 24 hours. She has no recent travel, no history of cancer, is otherwise healthy. Vital signs and physical exam are unremarkable except for slight calf swelling. You assign her a low pretest probability using a clinical scoring tool. What is the next best step in evaluation? A. Order a compression ultrasound. B. Begin empiric anticoagulation. C. Order a D-dimer test. D. Order MRI venography. And E. Discharge without further work. You have a 56-year-old woman, mild left leg discomfort and swelling for 24 hours. No recent travel, no history of cancer, otherwise healthy. Vitals and physical exam are fine. You assign a low pretest probability. So in other words, the question is asking you, in your evaluation of a patient with possible DVT, if the pretest probability is low, what's your next best step? That's how I should. That's another way I can put the question, right? If you are evaluating a patient with DVT and your pretest probability is low, what do you do next? And what you do next is you order a D-dimer test. So C is the correct answer. In patients with low pretest probability, D-dimer testing is appropriate to rule out DVT non-invasive. So that's what you do. That's what you have to do. Next question. You have a 65-year-old man who presents with new onset leg swelling and warmth. He is 4 weeks post hip surgery and has been mostly immobile at home. His Wells score suggests high pretest probability for DVT. A D dimer is ordered and it returns negative. What's the most appropriate next step? A. Reassure the patient to discharge home. B. Repeat the D dimer in 48 hours. C. Proceed to compression ultrasound. D. Diagnose cellulitis and treat with antibiotics. And E. Order venography. What will you do? You have a patient seems to have some risk factors for DVT. You do your D dimer, it returns negative, but the patient seems to have a high pretest probability of DVT. What do you do? What do you do? And the correct answer is C. You're going to proceed to compression ultrasound. You're going to proceed to compression ultrasound. Why? If you have a patient who is high risk, D dimer is not sufficient to rule out DVT. Imaging is required. And I'm going to have a special class focus on these things. Well scoring. When do you go ahead and do ultrasound? When do you want to do D-dimer before you consider ultrasound? Because this is very, very critical. You need to know those steps so you can be able to ace any question which comes around the well score. You can't go into any board exam, be it MCQ1 and NAC OSCE, AMC, PLAB, USMLE, without understanding well score very well. Today, we will not dive deep into wealth call, but I'm just teasing it out, okay, so that you can be able to get it. Doctors, so what I'm trying to present here is in DVT, don't just rush. Oh, especially in the board exam, it's D-dimer, ultrasound, and then we go. And then the complication is pulmonary embolism. There's so many nuances you need to know. Patients with high pretest probability, patients with low pretest probability. What do you do? How do you navigate that maze so that in the board exam you're able to ace it and ace it very well? Okay. Good. So let's do a deep dive. Let's do a deep dive. Let's do a deep dive. Doctors, I have a question. How has the class been so far? How has the class been so far? Don't just tell me. Like, what are some nuances you're learning which you hadn't paid attention to when you had learned DVT? What are some nuances you are learning now? Don't just tell me, oh, the class is going good. No, I want to get good feedback, proper feedback, so that I'll know that you are really, really following. You gave me one of the answers. I said, no. All of you, Dr. Sabine, all of you who have given, what are you learning from the class? I want to know. What is one thing which has stood out for you in the class today? Okay, so one is the Homan's sign thing because I know it's something a lot of people depend on. Dr. Joanna De Cruz also says it's wonderful. You break it down so well, Sally. And that's how it is, in the MedCognito portal as well, breaking it down so that you can really get superb learning, high frequency. Homan sign. Look like the Homan sign really got people. And Dr. Musima Mahapa says native to focus on epidemiology. That was very enlightening. Okay. So let's continue. Let's continue. So let's do a deep dive into labs, differential diagnosis in suspected DVT. Okay. Now, some people may, sorry, let me see this. Someone also says exam is very, yes, and making the decision when the dimer is negative. Yes, we will have, in fact, I will talk organize a class. We may do part two, because this is part one. We may do part two where we actually break things down and maybe pick the well score itself, analyze the well score. How do you deal with this in the board exam when you have a well score of this or those kinds of things? We have to do it. We have to do it. We have to do it. I promise you that we'll do it. And I also promised you last week. What did we learn last week? Last week was decreased level of consciousness, and remember that we only focused on the metabolic issues. So there are there are two other concerns. We talked about anatomical pathology issues and toxicology issues, which all can cause decreased level of consciousness. So I may have to go back and pick those as well. Okay, doctors, preparing for the Q1 is not a rush at all. It's about understanding various concepts and breaking it down. It's about understanding various concepts, and that is why I love to do this. So, role of routine labs: complete blood count, serum chemistries, liver function tests, and coagulation studies. They are not useful to diagnose DVT. You don't diagnose DVT with any of these. However, why do we do routine labs in patients with DVT? Number one, it is to exclude other causes of symptoms, like if the patient has an infection, if the patient has a liver disease. Okay. Number two, it's also to provide baseline values for anticoagulation therapy, like platelet count. So you know that, okay, before we started the anticoagulation, this was the patient's platelet count, and you can track it over the period. Okay? And it also provides baseline values for anticoagulation therapy, and it helps you to uncover underlying cause of DVT. Why did this young man who is able-bodied and works develop a DVT? Okay, so let's do some investigations, and that is when you go boom. Okay, it looks like maybe this patient some malignancy which was not picked up. That is why the patient has developed DVT. So you do those labs not because they confirm DVT, but they help you to navigate that maze. What about D-dimer? This is the only slide I'll talk about D-dimer because we won't have another class where I'll go deep into it. Okay, you have to understand that D-dimer is a fibrin degradation product, and it is highly sensitive but not specific. Let me say it again. Please write this down. D-dimer is highly sensitive but not specific. Let me say it again. D-dimer is highly sensitive for DVT, but not specific. It is only used in patients with low or moderate pre-test probability. Mhm. If you have any patient with a high pre-test probability DVT, don't waste your time with D-dimer. When do you use D-dimer? Use it in patients with low or moderate pre-test probability. And that is where the Wells school comes in. But I'm not going to deal with that today. I want us to understand the foundations of the DVT. You know what? For those who go into for those who go into the Canadian, who go into residency, and those who may do plus one, do you know that for those who are currently doing emergency medicine plus one, approach to DVT is whole objective out of the 35 objectives they need to learn for that particular exam. Mm. That is why I'm taking my time, because you realize that as you study the Canadian healthcare system and as you study the exam models, MCQ1, CCFP, CCFP, emergency medicine, or CCFP, with whatever it is you want to do, you realize that some of the objectives run through. So if you have this objective running through the CCFP emergency medicine exam as well as the MCQ one, that tells you that this is a very important thing to appreciate, and how to break it down with the various greatest probabilities so that you can get the best out of it. So you use dimer if the patient has a low or moderate greatest probability. If the greatest probability is high, don't worry your head. Go ahead and get your ultrasound. Okay. Now, what you also have to understand is that D-dimer cannot confirm DVT. It cannot confirm DVT. But a negative D, so assuming you do the D-dimer and D-dimer is positive and it's very high, it does not confirm DVT. But so what's the rule of? However, if you do D dimer and it is negative in low risk patients, remember the two things you can rule out DVT. So when can D dimer to rule out DVT? Number one, the patient must be low risk. Number two, the D dimer must be negative. So you can have a patient with high risk, but D dimer is still negative. Doc, please don't send that patient home. Kindly take your time and get your ultrasound. The only time you say that I have used D dimer to rule out DVT, let me make my screen bigger so you can tell exactly what I'm saying. The only time you say that I'm going to use D dimer to rule out DVT is under two conditions. Number one, D dimer is negative. Number two, there's a low risk probability. And someone just asked me the question. Dr. Kulawale is asking the question, how to rule out the negatives. Doc, that's what I'm saying. I'm going to have a class and we'll deal with that. Today we are setting the foundations. But even the foundations have so many things we need to appreciate that I don't want us to rush through this. Because this is where a lot of candidates in the board exam. When it comes to low risk probability, high risk probability, requesting D dimer. Okay. So, so let's go back. So we're going to look at differential diagnosis of DVT, but we are going to use equations. I'm not going to give you just MCQs and tell me. What I've seen is that at times you need to actually know. So today, if you see this guy, whenever you go through our videos and you see this guy, that means you're about to do some MedCognito calculation. Okay? So we're going to start. So what you do is you have to tell me the actual diagnosis. So in a board exam, if you are told that there's a patient with acute calf pain and there was a pop sound during and the pain is in the calf, what is the diagnosis? So that's how I'm going to go. So I'm looking at all the differential diagnosis of DVT, but I'm doing it in the context of an equation, right? So if I give it to you, then you tell me what the answer is. So Dr. Jagdeep says Achilles rupture. Who else has something different to say? Achilles rupture. That's what Dr. Jagdeep is saying. Achilles tendon rupture. Achilles tendon rupture. That's what a lot of people are saying. Okay. So what is the correct answer here? So we're looking at now the differential diagnosis of DVT. So it is calf muscle tear. It can be plantaris rupture or Achilles rupture, right? So why is it not DVT? Because in this case, we're saying that there was activity. So there's a mechanical trigger. Doctors, please, these differentials, I need you to write every single one of them. Their unique characteristic. So the unique characteristic is what I've labeled as why not DVT. Okay. So Achilles rupture, when you are in a board exam, how can you tell that this is actually Achilles rupture? Because there should be a history of mechanical trigger. Either the patient was jumping, either the patient was running. Number two, the pain must be acute and sharp, and it must also have a popping sensation. That's the second thing. So thank you very much, Dr. Ronnie Lankela says basketball. So I can, instead of acute calf pain, a basketball player who just jumped, dunked, and landed. Boom. Achilles rupture. Number three, ultrasound may show bleeding thrombosis. And number four, there may be bruising near the ankle. So these are things I want you to. So in your board exam, how do you pick up Achilles rupture? How do you pick up Achilles rupture in your board exam? Four things you must know. Four things you must master. Number one, there must be a mechanical trigger. Number two, there must be acute sharp pain, popping sensation. Number three, if you do the ultrasound, you don't see a clot, you don't see thrombosis, rather you see bleeding. And number five or number four, there must be bruising near the ankle. These are the four things. These are the four things, doctor. So please, I need you to write this down, take a picture, send it to me on WhatsApp. Please, all of you. My WhatsApp number is +1 306 891 5649. They are dealing with the differentials, and the differentials also open up a whole class on its own. So this is review of Achilles tendon rupture quickly. This is how it applies in your board exam. So make sure you write Achilles rupture. How does that differentiate, or how is that separate from DVT? Next question I have for you is this. Oh no, let's go through it. How are you going to pick up a calf muscle tear in your board exam? Look for that word, popping sound during exertion. Number two, the pain was acute. Pain is localized to the calf muscle, and there's bruising at the ankle. These three things. So this is how the med bullet in MedCognito also come across. So you see one slide, and we just give the bullet point. How do you identify this? Popping sound during exertion, acute pain localized to the calf, bruising at the ankle. Boom. This is how med bullets look like. And as I was saying, in the MedCognito program, you have more than 3,400 med bullets. This can be found in the family medicine portal alone. Okay, good. Let's go to the next one. You have a patient who comes in with red, warm leg, there is fever, and there are skipped areas of redness. Red, warm leg, fever, skipped areas of redness. Okay. Is my voice clear now, doctors? Is my voice clear? Is my voice clear now? I want to know. Is it clear? Is it better now? Is it smooth? So, red leg, warm leg, fever, skipped areas of redness. Beautiful. And the answer is bacterial cellulitis. Cellulitis. Okay. Now, why is this not DVT? But there's okay, before we move on, out of these four things, red leg, warm leg, fever, skipped areas, which of these features also can be seen in a patient with DVT? We said fever, constitutional symptoms, and patchy erythema, they point to cellulitis. It may affect multiple skin levels, and there's as maybe actually skin trauma or dystonia. Now, how to pick up cellulitis from DVT? There may be fever, there may be chills, warmth and redness that skips some areas, known venous insufficiency or lymphedema. The caution here is this: DVT can also cause fever. Take your time and get this. DVT can also cause fever. And so when you see fever, don't just say, oh, it can't be DVT. DVT can also cause fever. Okay? Mhm. DVT can also cause fever. Now, have another one. You have a patient with linear tender vein, a palpable cord, and local redness. Linear tender vein, a palpable cord, and local redness. What's your diagnosis? Linear tender vein, a palpable cord, and local redness. What's your diagnosis? Linear tender vein, palpable cord, and local redness. So we are looking at the differentials, but we are looking at it from um, a mathematical perspective. So the answer is superficial thrombophlebitis. Superficial thrombophlebitis. So why is it not DVT? Superficial thrombophlebitis affects superficial, not deep veins. Remember, DVT affects the deep veins. Superficial thrombophlebitis affects superficial veins. Now, superficial thrombophlebitis presents as a palpable tender cord under the skin, and it may coexist with or it can lead to DVT. So if you have a patient with superficial thrombophlebitis, don't just say, "Oh, you can go home." No, it can coexist with DVT. It can lead to DVT. So you need to do a workup for the patient. And what are the exam clues for superficial thrombophlebitis? There's tender palpable vein. There's a red line along the superficial vein course. And you may also be told that, oh, this patient had a history of IV insertion or the patient has varicose vein. Varicose vein or IV insertion, red line along the superficial course, and tender palpable vein. Okay. What about chronic leg swelling and varicose veins plus worsening with standing? You have a patient who has chronic leg swelling, varicose veins, and this worsens with standing. What's your differential diagnosis? Chronic leg swelling, varicose veins, it worsens with standing. What's your differential diagnosis? Chronic leg swelling in a board exam, varicose veins in a board exam, it worsens with standing. What's your differential diagnosis? What's your diagnosis? Let me see. What's your diagnosis? The diagnosis is venous valvular insufficiency. Venous valvular insufficiency. So why is it not DVT? This patient has chronic, it's not acute. And swelling worsens with standing and it improves with elevation and may have stasis or pigmentation. And there can be skin changes, or the patient may even have venous ulcers. Now, this is a very important one. For those in MedCognito and everybody, please, I want you to send me a WhatsApp right or after the class. This is an assignment. What is the difference, or what are the differences between venous ulcers and arterial ulcers? Venous ulcers and arterial ulcers, because we are saying this patient has chronic leg swelling, varicose veins, western withstanding, right? So this patient may have venous valvular insufficiency. And we said that one of the features of venous valvular insufficiency, the patient may have stasis pigmentation, skin changes, or ulcers. So I'm asking you, please send me a what. It can be a video, like a video note. It can be a screenshot. How do you distinguish between venous ulcers and arterial ulcers? Those in MedCognito, send it to me in the WhatsApp group. Those who are not MedCognito candidates, who want to be MedCognito candidates, send it to me personally on my WhatsApp at +1 306 891 5649 +1 306 891 5649 +1 306 891 5649. So, what are the exam clues for venous valvular insufficiency? There's chronic swelling where there may be visible varicosity. It is worse at the end of the day. Worse at the end of the day. And then there can be dark skin pigmentation on the lower leg. Dark skin pigmentation on the lower leg. Venous valvular insufficiency. Okay. What about you have this patient? Chronic non-pitting leg edema, and this patient has a history of cancer or surgery. History of cancer or surgery. Chronic non-pitting leg edema, and this patient has a history of cancer or surgery. Chronic non-pitting leg edema. This patient has a history of cancer or surgery. What's the diagnosis? I see doctors talking about lymphedema, lymphatic obstruction. Beautiful. So why is it not DVT? Non-pitting edema is occurring because there's fibrosis, not fluid. And it is associated with malignancy, pelvic surgery, or radiation. So the reason why it is non-pitting is because it is fibrosis, right? The swelling is gradual and it is persistent. Gradual and persistent swelling. Gradual persistent swelling. Gradual persistent swelling. So chronic non-pitting leg edema, history of cancer or surgery, okay, lymphedema, and the swelling is gradual. Meanwhile, DVT swelling occurs within a very short. So, lymphedema clues. How to pick up lymphedema clues? There's a history of pelvic central radiation. Okay, lymphedema, or the swelling is hard, it is non-pitting, and we've learned that it is as a result of fibrosis, slowly progressive swelling over time. Slowly progressive swelling over time. And this one, I'm not going to quiz you on it. So you have a patient with posterior leg, knee mass, calf swelling, and there is bruising at the ankle. Posterior knee mass, calf swelling, and is bruising at the ankle. What's your diagnosis? It could be a popliteal Baker's cyst which has ruptured. Popliteal Baker's cyst which has ruptured. Now, why is it not DVT? Because this swelling and bruising is as a result of the fluid leak. So if I could show you my knee, my funny knee, you can see it. Let me see if I can make this thing bigger. I can, my table is too long. I can't show you. I'm using a standing desk. I would have shown you my knee and shown you where the Baker's cyst usually is. So when the Baker's cyst ruptures, it trickles down, right? The patient becomes your knee pain. There can be stiffness, and it may mimic DVT, especially when that cyst ruptures, right? And it can lead to ankle bruising pain. So we've gone through all this. And with this, with popliteal ruptured cyst, there's bruising around the ankle, normal Doppler. Okay. Okay. So now let's talk about knee swelling, joint pain, and limited range of motion. You have a patient with knee swelling, joint pain, and limited range of motion in the knee. What's your what's your diagnosis? Knee swelling, joint pain, and limited range of motion. What's your diagnosis? Good, good. It's arthritis, septic arthritis. And so it can be an inflammatory knee pathology. It can be septic arthritis, it can even be flare up of regular arthritis, right? Pseudo gout of the knee, right? So the pain is localized to the joints, not along the veins. And usually it is worse with moving or flexion. And it may be related to underlying arthritis or injury. So how do you pick up inflammatory knee pathology? Limited knee range of motion, pain localized to the knee joint, and then a history of osteoarthritis. Okay. What about a patient with bilateral leg swelling, no inflammation? The patient is on amulot. Bilateral leg, there's no inflammation, and you're told the patient is on calcium channel blocker. What's your diagnosis? Doctors, what's your diagnosis? Sure. So it could be a side effect or what? It could be a side effect. So it could be drug induced edema, right? Like from a calcium channel blocker, like or it could be even heart failure as well. Can do the same. So usually in those cases, the swelling is bilateral. Often it is painless, right? Often it is painless. There's no reddening or warmth or tenderness. Okay, and it can be associated with medications or signs of heart failure. When we're talking about the signs of heart failure, when talking about heart failure, you have to know that right-sided heart failure, left-sided heart failure, their clinical signs. What are you going to see chest X-ray in heart failure? I'm not going to go into that. This is just something I'm drawing attention to. So, exam clues for that patient with calcium channel blocker like amlodipine, nifedipine, you know, or the patient has heart failure, bilateral edema, patient is on a calcium channel blocker, no fever or pain, and there's a history of congestive heart failure, shortness of breath or apnea, right? These are the things we want to pay attention to. So, quick one, before we go into the active recall, because that's the next part of the class. Oh, wow, we've already done 1 hour, 12 minutes. Whew. Doctors, are you tired? Are you tired? Because we are going to the last part of the class. Are you tired? If you're not tired, then we'll move on. But I'm just sharing this that if you want to reach out, please do. We have a class tonight on MCQ again. And if you want to join us, we are very glad to welcome you. But just send a WhatsApp to me if you want to talk to me. Usually after the class like this, reach out. So we will deal with it on a first come first served basis. And for those who texted me last night that I couldn't respond as well, I had a engagement, and so I've not really been able to attend to just right after the class. I'm going to spend time, and everybody who sends me a message, I'm going to respond. If you want to speak to me about joining the class as well, +1 3068 75649. There's so many packages. You can come in for a month, for 3 months, for 2 months, for 4 months, whatever it is that you want. We are here to do for you. We usually encourage that you go for at least 6 months, but some people have the exam in September. So just and for those on the Zoom call, I've seen that a lot of people times call me and they say, "Oh, I want to write my exam in December." Doc, last date for this year's exam is October 22nd. Okay, for 22nd. So if you're planning on writing an exam, there's not going to be any exam in November. There's not going to be any exam in December. The last date for this year is October 22nd. So please note that if you really want to write your exam this year, that's what you have to pay attention to. Okay, so let's start with the active recall, and then we are done. So, what's the most serious complication of untreated DVT? This one is speed race. What's the most serious complication of untreated DVT? What's the most serious complication of untreated? The most serious complication of untreated DVT. Beautiful, beautiful. Pulmonary embolism. Boom. This is straight shooting. We are not joking around at all. Serious complication of untreated DVT. Name two populations who are at risk of DVT. Two populations who are at higher risk for DVT. Two groups of people who are at higher risk of DVT. Please answer me. Two groups of people at higher risk of DVT. Two groups of people who are at high risk of DVT. Good. Surgical patients, so post-surgical patients, patients who have had cancer, patients who are hospitalized, hormonal contraceptive users, right? Even someone talked about pregnancy, patients who have had especially orthopedic surgeries like hip, all that. Okay, good. What's the most reliable physical exam finding for DVT in the leg? What's the most reliable physical exam finding for DVT in the leg? Most reliable physical exam finding for DVT in the leg. What's the most reliable? Most reliable. What's the most reliable physical exam finding in the leg? Good. A difference in calf circumference, more than 3 centimeters between the legs. Beautiful, beautiful, beautiful. Dr. A, that was powerful. Good. A patient has massive thigh swelling and buttock pain after pelvic surgery. What should you suspect? You have a patient who has had massive thigh swelling and buttocks pain after pelvic surgery. What are you going to suspect? What are you going to suspect, doctor? Let's go. This is speed race. Patient has massive thigh swelling and buttocks pain after pelvic surgery. What should you suspect? What should you suspect? Good. Good. Dr. Ronnie, you're looking at iliac vein or proximal deep vein thrombosis. Iliac vein or proximal deep vein thrombosis. We talked about all these parts. Okay. What are some key features of DVT on physical exam? Key features of DVT on physical exam. Key features of DVT on physical exam. Key features of DVT on physical exam. Here are some of them. Okay. So there can be lateral swelling. Hmm. Hmm. I see some of you out there. Unilateral swelling, calf warmth, calf warmth, tenderness along the deep veins, pitting edema, and increased calf circumference. Increased calf circumference. Okay, increased calf circumference. Okay, I have another question for you. Are routine labs like CBC and LFT helpful in diagnosing DVT? When it's diagnosing DVT, are routine labs like CBC, LFTs helpful in diagnosing DVT? Good. I see a lot of doctors saying no. They are not diagnostic, but they can help to identify other underlying causes or differentials. Good, good. What's the primary clinical utility of D-dimer in the setting of suspected DVT? What's the primary clinical utility of D-dimer in the setting of suspected DVT? What is the primary clinical utility of DVT, of D-dimer, in the setting of suspected DVT? Tell me. What's the primary clinical utility of D-dimer in the setting of suspected DVT? And the answer is it is to rule out. It is to rule out DVT in patients with low or moderate pretest probability. It is to rule out because there are so many causes of elevated D dimer. DVT is not the only cause of elevated D dimer. Okay, now can a normal D dimer level definitely rule out DVT in all patients? Can a normal D dimer level definitively rule out DVT in all patients? Can a normal D dimer level definitely rule out DVT in all patients? Dr. Kini says no. You can only rule out DVT with D dimer in two situations or a combination of two situations. Number one, when there's a low, moderate risk, free test probability, and number two, when the D dimer. So when these two come together, that is when you can confidently say, when the patient has a high risk pre-test probability, you can't rule it out. What's the most common non-DVT cause of leg pain in patients with suspected DVT? Ha 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 ha. What is the most common non-DVT cause of leg pain in patients with suspected? What is the most common non-DVT cause of leg pain in patients with suspected DVT? What's the most common non-DVT cause of patients suspected DVT? And the correct answer is muscle strain. Muscle strain. Muscle strain. Muscle strain. Muscle tear. Okay, so we are looking at all the various differentials, twisting injury, those three things. So far as they have to do with muscle, you're thinking about it. Now, why is D-dimer considered sensitive but not specific for DVT? Why is D-dimer considered sensitive but not specific for DVT? Why? 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 Why is D-dimer considered sensitive but not specific for DVT? The correct answer is it's because many conditions, like infection, trauma, cancer, recent surgery, can all elevate the D dimer. Okay, even in the absence of DVT. Okay, D dimer is not only positive in DVT alone. You can see elevated D dimer in patients with infection, cancer, trauma, recent surgery. Okay, good. So, doctors, I have a question before I introduce what we need to do in the next class. Was this class helpful? Please, was the class helpful? I want to know. Was the class helpful? Did it help to break things down? And maybe I don't know whether someone wants to join me. I can share an invite and you can join and let me know what are some of the things you would expect, you know, going forward, in this class. In fact, I want you to talk to me. I can take only 8 people. So if you want to join me, I'm dropping the link. Just click on it. Make sure that your camera is. Just click on it and join me. Let's talk in these classes because I'm planning on next time we have to go focus on suspected first DVT evaluation. Okay, how to use the well score, DVT in patients with past history of DVT, alternative imaging in the patient with DVT. It is only Doppler ultrasound with anticoagulation, DVT in special populations. These are all very. But I want to hear from you. I want to hear from you. What are other things you want to see? So, that's what I said. That we've not also completed that, but these are other topics that which are very important. So I'm just introducing them, and then we can go back and pick up. Okay. So if you want to just join me live, let me know. I can share my. I've shared the link. You can just click on it. Just make sure that your camera is on. If not, then that is it. These are future things we need to look out. Okay. These are future topics we need to review. So doctors, awesome. It's been great. I hope it was a good Sunday well spent. Please, for those who are still interested in joining us at MedCognito, the phone number is +1 306 891 5649. You can just call me quickly, sign you up, whether you want 1 month access, 3 month access, 6 month access. You have your mock exams now. We have a question bank program as well. You know. Mhm. All right, doctors. Thank you very much. +1 306 891 5649. Give me a call right away. Let's study. Awesome. Self. God bless you. Bye. Bye.